Our next presenter is Dr. Livia Garzia, who's going to tell us about sarcoma, her sarcoma lab research.
Thank you. Okay, so first I would like to thank you all for coming out on this nice and sunny Wednesday afternoon to listen to our exciting progress in pediatric oncology. So my name is Livia. I come originally from Italy, then through Toronto, I landed here in Montreal, and I started my lab about 2 years ago. The main focus of my lab is to understand the mechanism of metastasis and resistance to therapy in pediatric sarcomas and brain cancers. So because right after me, there is a world authority on speaking about brain cancers, I will limit my intervention to pediatric sarcomas today. Okay, so childhood sarcomas are really complicated. As you learned from Catherine, who spoke just before me, every cell in the body has a blueprint, has a program of what to do in life, and this program can get broken. So if some cells have a broken program, they can become childhood cancers. So in the case of sarcomas, the breaking down of the cell blueprint, the breaking down of the DNA, is extremely complex. Instead of having one word wrong, this blueprint is completely rearranged, and it's really hard to tell which event started the whole tumor cascade. So one of the reasons why sarcomas are so complicated is that, first of all, they can form in different parts of the body. As you see in the cartoon there on the slide, we have lymph vessels, blood vessels, nerves, muscle, tendon, bones, and cartilage. All these tissues in the body can be the site of origin of sarcomas. And this is because sarcomas start from a specific cell type in the body that's called mesenchymal stem cell. So this stem cell is able to make all the different types of what is called connective tissue in the body, from bone, fat, muscle, and vessels and lymph nodes. So the complexity of sarcomas in the clinic, the fact that they can come from different sides of the body, also reflects in their complexity of their blueprint. Thankfully, sarcomas are rare. So there is not so many, and there is about 20,000 new cases in the United States every year. So sometimes you will see that we researchers use a lot data derived from the United States. It's because they have a very big population, and so it's easier for us to understand statistically what's going on in these very rare cancers. So if you want to think about what happens in Canada, you can just transpose these numbers divided by a factor of 10, because our population is 10 times smaller. So 12,000 new cases of sarcomas in the States, about 120 1,200 in Canada every year. This type of cancers are extremely aggressive, and they're usually treated with a combination of surgery, chemotherapy, and radiation. And of course, the type of treatment depends on the type of sarcoma and where they come from in the body. And to understand what are the differences between the different types of sarcomas and what makes some worse than others, my lab started the USBG project, which is understanding sarcoma biology through genomics. So we started a massive tumor bank at the Research Institute, which collected about 300 samples in about 2 years. And this is really the result of an extremely tight research and clinical community that is here at the MUHC. So we work really closely with clinician scientists, and all the healthcare professionals that participate in the pediatric oncology care team. So this This is an example of what our tumor bank looks like. So I don't want you to read the labels because that's not the point of the slide, but what I would really want to focus your attention on is that some columns are much higher than others. So some patients, some type of tumors are more frequent. So we are able to collect more samples, and we are able to understand better what is actually causing this type of diseases. Others are very, very rare. So in 2 years, we only saw 1 patient of a certain type of cancer. So that kind of like gives you an idea how hard it is to study this type of cancers where we don't actually have access to many of this type of tumors to analyze it in our molecular biology approaches. So as I was telling you, one of the main interests of my lab is to understand how to improve the outcome of patients that have metastasis. So every patient that has a sarcoma is at risk of its tumor to come back in a different location of the body. Let's say that you first have a sarcoma in the femur. So the surgeon goes and takes it out, and then you probably go through cycles of chemotherapy and radiation. You're in remission, your cancer is gone. However, we know that 20% of these patients will have their tumor come back in a completely different position, in the lungs, in the brain, in another bone. And I mean, to be totally honest with you, we don't really understand why and how this happens. And one of the reasons why is once the tumor spreads and metastasizes, that's the term that clinician and clinician scientists use, usually there is no benefit for the patients to have their metastatic tumor removed. So it's really hard for us to study something that we cannot really access. So to overcome this limitation, my lab decided to work closely with clinicians in our sarcoma clinic and collect biopsies also from metastatic sites when it's safe to do so and when there is a possible advantage for the patient in having their metastatic disease sampled. So we were able to do this in a few cases, and then we perform genetic profiling of the tumors, like Catherine explained to you. So we read this blueprint, and we try to figure out which events are happening that make this tumor really aggressive. And by reading the blueprint, we can only make educated guesses on what is happening, because there is not only one thing that's broken, it's many things at the same time, and it's really hard to understand which one is important and which one is just, secondary. Sometimes stem cells have a first broken piece in their blueprint, and that changes them, and then they accumulate many more other mutations and many more other breakages, and we can't tell which one is important and which one is just a consequence of it. So once we have what we call the profiling of the metastatic tumors and the relapses, we predict candidate genes for precision medicine approaches like Catherine described before. And my lab also uses a complementary approach. We take the tumor cells that come from the metastatic patient and we put them in special mice. So you know that if I put a human tissue in a mouse or a human tissue in another person, there is something called rejection, right? So this doesn't usually work. So scientists were able to create special animals for research. They are able to accept transplants from human tissues, and we make something that's called mouse avatars. So the patient tumor now grows in animals in the lab. So we can use a double approach that's based on reading the blueprint of the metastatic tumor and at the same time have the tumor growing in the mice so we don't have to sample the tumor from the person again. By combining these two approaches, then we can go down to few candidate things that we think are going to be important for curing that specific cancer. So I want to show you one of the examples that we recently had in collaboration with Dr. Mitchell. We accessed a bone sarcoma that was metastatic to the lungs. And reading the genetic code of this tumor, we appreciated there were several mutations that could have been causing it. So the problem was which one was really important and which one we had good drugs to try. So to do that, we took the tumor cells that we had put it in the mice, and we had put it in vitro in culture, and we tested different drugs based on the candidate genes that we derived from the genetic screening. And what we were able to find, it was that among all the candidates, we found one drug that's called dinaciclib, which was really efficient in clearing the tumor in mice. So if you look at the left side of the slide, this shows you the schematic of a little mouse, and then it shows you the pelvic bone and the femur in the CT image. And we put the cells from the patient, from the human lungs where they had metastasized, back into the bone of the mouse, and they form tumors in the mice. Then we treat the mice with the drug that we would like to give to the patients, and we see if it works. Some of the drugs we tested didn't work. So some of the candidate genes that were broken in the blueprint of the primary tumor actually were just there as a bystander effect of tumors, but they were not actually driving the disease. When we treated the mice with this other drug called dinaciclib, instead the tumor shrunk. So if you look on the right side of the slide in blue, it shows how is growing the mass of the tumors in mice that we did not treat. And in red, instead, is the growth curve of the tumor volume in mice that were treated with the drug. See, when the treatment starts, which is the green triangle, the tumors disappear. So we know that for patients that have a certain type of mutation, in this case is called amplification of VEGF, and of this gene called the VEGF, they respond really well to dinaciclib in osteosarcoma. Of course, we plan to understand what is the mechanism of this, and if the tumors stay low for a long time, or if they come back after we stop the drug. And we also want to try to understand for how many osteosarcoma patients this is true, and if we can predict from the primary tumor or the metastasis which ones are the good candidates to be treated with this type of drug. And I just want to thank my lab, that is actually all the people that did the work. And it's the people there in the top right corner of the slide. And we are, that picture was taken at our TerryFox run. We were very lucky to receive a very generous grant from the TerryFox Foundation last year. And so we participated to their 5 kilometers run last week. And it's a very Canadian lab. We are 8 people from 5 different countries. And I also want to thank you all for listening to me and all our very generous collaborators and sponsors.